right? Okay, so let's discuss this right now. So when we're talking about the anatomy of the respiratory system, right? We kind of know that the respiratory system is important for, number one, bringing air and oxygen into our lungs, right? So that's a real important concept to go. But just keep in mind that when we're discussing this, that the respiratory system's main purpose then is not just to just bring air in, but we need to transfer everything into the bloodstream. So that's a big thing, all right? If we get oxygen and air into our lungs, that's only part of the job that we need to, that we started here. What we need to do is somehow bring that oxygen into the red blood cells found in our bloodstream. So the respiratory system and the cardiovascular system always works together, always. Now, when we, right here, right, the respiratory system and even the urinary system kind of works together. And one of the ways that it does is that, right, one of the main mechanisms for us to have a slightly basic pH of blood is to take carbon dioxide that we produce by aerobic respiration, mix it with water that we produce by aerobic respiration. And what happens then is the combination of carbon dioxide and water is going to produce something some of you might have heard of, sodium bicarbonate. Right? So that bicarbonate is a kind of a weak base, and it allows us to have a slightly, ever so slightly basic pH, right? So what happens is in the urinary system, we can get rid of that excess base, we can get rid of excess acids in our body, and it kind of helps titrate. So then our basic blood pH will be slightly basic at 7.4, right? So I'm using basic a lot, but I'm using it in the real chemical term, right? So respiration has three meanings. One, movement of air in and out of the lungs. Usually we call it that ventilation. The exchange between gases, between air and blood, and between blood and the tissue fluid, that's what we call usually respiration. So when we have oxygen that goes through the alveolar cells, goes into the red blood cells, and now we're carrying oxygen, well, that happens in the lungs, and then we carry it to our target tissue and release that oxygen in the target tissue. All right, we call that actual respiration. The usage of oxygen in cellular metabolism is also called aerobic respiration. So when we talk about these, just be careful about which specific aspects of the respiration we're talking about. When we talk about getting air in and out, we usually call it ventilation. When we discuss usage of oxygen, so then we can make ATPs, usually we call it aerobic respiration for a reason, right? So we just basically, hopefully, definitively quantifying which ones we're using. All right, functions of the respiratory system: oxygen and carbon dioxide exchange, speech, smell because of your nose, right? pH by limiting carbon dioxide, blood pressure by synthesis of angiotensin 2. Uh, Breathing creates pressure gradients between thorax and abdomen that promotes flow of lymph and venous blood. We kind of mentioned that last week when we started talking about the skeletal muscle pump, moving blood from your veins of your lower legs to your abdomen. And in the abdomen, we have the respiratory pump or thoracic pump, moving blood from your abdomen back to the heart, right? Valsalva maneuver. We don't think it's important, right? But it's actually is important. It's not just to expel abdominal contents during childbirth. Usually that's what we're thinking of, but we use it during a lot of different processes. Usually they're not very comfortable ones to talk about, right? Defecation, urination. Those are you bearing down. That's a Valsalva. Right. Now we'll talk specifically about the anatomy coming up, the nose, pharynx, larynx, trachea, bronchi, lungs. Right. Now we're just introducing the concept. That's why nothing's really highlighted here. Incoming air eventually stops in what looks like little tiny balloons called alveolar cells. All right, we have millions of these thin-walled microscopic air sacs, and this is where gas exchange. Air is going to come in through your system of ducts, is going to open up our balloon, alveoli, The more you open it up, the more you spread the cell. The more you spread the cell, the less plasma membrane that you have for oxygen to have to go through. What happens then? We want these cells to be as thinly walled as possible. That makes it easier for all the gases to exchange. When we have an issue, when some of the, migration of other cells there, and we have a thickening of these alveolar cells, it makes it much harder for us to get air through. Now, the conducting division of the respiratory system, just like the name says, conducts air towards the cells that actually will be where gas exchange occurs. So we have two main divisions that we're going to talk about in the respiratory system. The conducting division, all it does is funnel air. That's it. There's no gas exchange, there's no nutrient exchange, nothing. All we're doing is moving air. Now, we're going to talk about in a second the respiratory division is where we actually have the air going and terminating in that region. Then we blow up the balloon, thin it out, and now we have gas exchange, right? And in order to have that, we have to have alveoli, right? So there's a conducting division, right? And then the respiratory division right here. The respiratory division, actually where alveolar cells are, and this is where gas exchange occurs, right? Now, we also divide it into upper and lower respiratory tract infections or upper and lower respiratory tracts. Now, I mentioned infections for a reason, right? How many times have you been to a doctor and the doctor says, oh, you have an upper respiratory tract infection? And usually, what does that mean? That usually means you have a sore throat, right? Or you have a runny nose, that kind of stuff. Usually, it means that number one is less severe. So it's not comfortable, but it's usually not life-threatening either. You're not going to have a life-threatening sore throat, right? And we call it sore throat pharyngitis, by the way. So when we talk about upper respiratory tract, usually these are all part of the conducting part of the respiratory system. The lower respiratory tract infections are the ones that are found in the thorax. So these can include, right, alveoli, right, damage to the lungs, things like that. And when we talk about lower respiratory tract infections, now we're kind of a little bit more worried. Pneumonias, right? Bronchitis, that kind of stuff. All right, so pictures right here, upper respiratory tract, and then when we look in the lower respiratory tract, it's from this area, the trachea, downwards. So this whole area from your nose, right? You guys all know that the nose and your mouth are linked by a tube that we call the nasopharynx. There's a reason why usually when you're drinking something with a friend and they make you laugh, as you laugh, that liquid in your mouth goes up your nose and it gives you the most uncomfortable feeling, right? Why? It's because there's a tube here that connects your nose to your mouth to your nose right here. All right, that tube is called the nasopharynx right here. We bringing food and water and drinks to, right? This area is your mouth, but behind it, that tube continues down here. This is called the oropharynx. The oropharynx then continues down until you hit the epiglottis, right? Here's that flap that closes down. So then fluid, right, gets directed posteriorly to the esophagus and not anteriorly to the windpipe or trachea. The epiglottis there deflects fluid, so then it goes backwards, right? Now, we call that region where the epiglottis starts and where the vocal cords are. This region is called the laryngopharynx, and that's where we start dividing the digestive system in the back and the respiratory system in the front. Now, if you take a look, this esophagus, notice how it's very collapsed, right? It looks very small, doesn't it? Take a look at that. If you look at the windpipe, trachea, all the way down, it looks like it's completely open. The reason why is simple. The esophagus is completely made out of smooth muscle. And when there's no food in there, it collapses, right? Well, that area of your thyroid cartilage and then your trachea, well, that's made out of cartilage. And cartilage always stays open unless there's the epiglottis closing it down or the vocal cords closing it down, right? You always have an opening here, right? And usually the only time you don't is if there's something that kind of slips through and blocks it. Here's just more pictures. Hard palate is a bony area that separates your mouth from your nose. Soft palate ends at the uvula, that little punching bag at the very end, right? And the main purpose of the soft palate is when you eat, you force that food into the oropharynx. As you force it into oropharynx, it closes down the uvula and the soft palate, so then the food doesn't go up into your nose, right? Vocal cords, really important. We'll talk about coming up. Here's the epiglottis, that flap, and here's the right larynx, right? And this area in the back, the laryngopharynx, where we have the separation of respiratory system in the front, digestive system in the back. Warms, cleans, humidifies inhaled air, detects odors, serves as resonating chambers, amplifying our voice, giving it a specific sound quality as well. How many times when you answer your phone, you know immediately whether it's your mom or dad that called you, right? Whether you know, you don't even have to look, right? Nowadays, it's hard not to look, right? You can look at the phone number and know immediately if you should answer it. But in the old days, you'd pick up the phone and there was no caller ID. So I know it's hard to believe, right? In the old days, we used to have one phone line at home. So nobody had cell phones. So everybody had have just one phone line. And if you want to talk to a friend, that means everybody else in your family can't use a phone. Crazy, right? And you didn't have caller ID, so you're almost forced to answer it. And right when you answer your phone, usually you can tell who the person is that called just by their voice. Now, nowadays is a little bit, yeah, you don't need that kind of distinction. You can look on your caller ID right away and actually decide whether to answer or not answer, right? But back then, you didn't have caller ID. So what do? You force to answer it, right? Then you force to hang up right away if it's a bill collector, right? That's what we had to do back then. Now, I'm not going to spend too much time on the nose. And we'll talk some of these right here. Now, what I would kind of discuss here is just the cells that make up certain areas of your respiratory system are easily things I can ask on your next, lecture exam 5, right? So the thing about easy things that are high yield is if you understand that there's specific cells in specific regions of our body, right? Once you kind of realize that there's that distinction, you can answer 3, 4, 5 questions on it pretty easily. So the nose itself has a vestibule area that's the beginning of the nasal cavity. That's that opening right here, right where air goes in. That area is lined with stratified squamous epithelial cells. We have little hairs that blocks, sounds gross, insects, right? And more importantly, debris from entering the nose. So there are reasons why we have nose hairs, right? Besides just embarrassing us, the nose hairs are going to be there to prevent things that we don't want from coming in. Posteriorly, the nasal cavity opens into a larger chamber with not much open space. So right here, whoops, right? The nose itself, this is where I kind of highlight just because I think it's a little bit more important, right? We're going to see, I'm just going to, I think back here showed it a little bit better, right? You're going to see these kind of bony areas that kind of stick out. Now, what I want you to do when you get home, if you have a brother or sister or a significant other or mom and dad, right, look in their nose, right? On the lateral part of their nose right here, you should have these little bumps on here. Now, I say little, they're not little, they're pretty large, right? They're actually pieces of bone that's covered with mucous membrane and hairs. And they're found on the lateral surfaces of the nose. We call them conchas or meatuses, right? The superior, middle, inferior nasal concha, right? These are found on the lateral part of your nose, and they actually have a function, right? They project from the lateral walls towards the septum, right? Now, when we get sick, these conchas will be inflamed and enlarge, all right? They're going to release more mucus, and now it makes it harder to breathe. So normally its main job is to clean, warm, and moisten the air. But when it gets really inflamed, when we have an upper respiratory tract infection and it becomes really hard to breathe, we've all had that. We're trying to sleep. We can't sleep because we can't breathe out of our nose. So you try to mouth breathe and sleep. Hard, right? So usually you don't get much sleep that night. Well, one of the reasons is because these conchas are inflamed and your normal passage of air into your nose is already pretty restricted. Now that they're inflamed and they are, edematous, it becomes severely restricted and becomes really hard to breathe. Olfactory epithelium is found on the superior part of our nose. That olfactory epithelium detects odors, covers a small area on the roof of the nasal fossa, right? And it's going to have openings right here for our olfactory nerves to go through, right? And this is what it kind of looks like. This is the cribriform plate that forms that roof of our nostrils, right? The cribriform plate has all those tiny perforations. And all those tiny perforations allow our olfactory nerves to go through. So then we can smell through our nose. Perfect. Posterior part has what we call respiratory epithelium. I highlighted and underlined this. Might be on a test, all right? So this respiratory epithelium lines the rest of the nasal cavity except for the opening. The opening right there, right? I know I don't want to pick it, but you know what I mean, right? That opening is called the vestibule. That has stratified squamous cells. The rest of the nose has this respiratory epithelium. What is respiratory epithelium? Ciliated, pseudostratified columnar with lots of goblet cells. Now, this will make sense in a second, right? The cilia are motile, meaning they're going to move something. Goblet cells are going to produce a lot of mucus. So then any inhaled dust can get trapped by the mucus. And then the cilia will move it out, right? Either by forcing you to sneeze, or if it's small enough, the mucus that's found in the nose is going to be carried by the cilia down into your throat. So then you can swallow it, right? It's kind of gross, but we produce a lot of mucus every day. And 95% of the time, when you clear your throat, you're not spitting it out, right? Because that's pretty gross too. Right, the last thing you want to do is sit next to somebody that keeps spitting their mucus out into a tissue, right? That doesn't look good, does it? So what happens is usually 95% of the time when you're doing this, you're going to be swallowing that mucus that you just moved upwards, right? Part of that is functions of our pharyngeal muscles that constrict. Part of it is our what we call our mucociliary escalator. And his main purpose is to move mucus that we trapped, the cilia, if it's above your, if the mucus is above, your vocal cords, then the mucus moves the cilia moves that mucus towards the, vocal cords and epiglottis and allows you to swallow it. If it's below the vocal cords, right, the cilia moves the mucus upwards. So then you can get it into your laryngopharynx and swallow it, right? Now, the erectile tissue here, right, extensive venous plexus in the inferior concha. Every 30 or 60 minutes, erectile tissue on one side swells with blood, restricts airflow, right? Then most air directed to the other nostril and fossa, right? Allowing engorged site time to recover from drying. And preponderant flow of air shifts between right and left nostrils once or twice an hour. It's kind of crazy. We don't think about it. But about once or twice every hour, part of our nose closes off. So then we can shift that airflow, right? So then that in the next hour, we shift the other side. Just something kind of fun to discuss. All right. Now we're going to talk about the pharynx. Now notice that there's a lot of pictures in chapter 22, right? This one you probably don't want to show in front of any kids, right? So this is a sagittal cut of a person, and they're really doing a cut right down the person's middle, all right? We can see the corpus callosum. We can see that opening to the third ventricle here, right? Or to the lateral ventricles, right? You can see pons, medulla, spinal cord on the way down, right? You can also see how big the tongue is and how small, right? I don't know if you can even see it. The epiglottis is over here, right? Pharynx is your throat, right? So usually we think about it starting at your mouth level, but actually it starts in the nose level. So below, behind your nose, all the way in the posterior part, right? We're gonna see the nasopharynx. Posterior to nasal apertures, above soft palate, receives auditory tubes, contains pharyngeal tonsils. Now, a lot of this is going to be on our, word list, right, for our models, right? You're gonna need to know nasal, oral, and laryngo, right? Laryngopharynx and oropharynx. We're gonna see in a second that what I want you to know about these is number one, where they're found. Number two, what type of cells are found here, right? Where they're found, nasopharynx just behind your nose, all the way to your soft palate, right? Oropharynx is between your soft palate and your epiglottis. Laryngopharynx is between your epiglottis and the cricoid. Usually we say between your epiglottis and your vocal cords, right? Your cricoids are where the vocal cords are found. Cricoid's pretty big, so again, right? The whole tube is a pharynx. We split it up into the nasal, oral, and then down here, laryngo. Right? Nasopharynx. Right? Again, I highlight all this because this is kind of easy, high yield stuff. All right. Nasopharynx has that respiratory epithelium. This is that's what I want you to remember it by. Right. It's mentioned previously before, but this is respiratory epithelium is that simple or pseudostratified columnar with cilia. Right. That's found in the nasopharynx, but then it changes, right? It changes because in the oral and the laryngopharynx, right, you might be introducing food, food that's spicy, food that's really has a lot of heat, right? It's really hot. You can be drinking hot coffee, right? So all this can cause damage unless you have a certain cell type. The cell type that I've mentioned way back in the first couple lectures, right? The cell types that are protective, stratified squamish, right? So it makes sense that the oropharynx contains stratified squamish cells because that's where we're introducing food from your mouth to your oropharynx next. It also makes sense because the oropharynx is connected, right, and brings that food down to the next pharynx, the laryngopharynx right here. What happens then? The laryngopharynx also need to have protection because it's also receiving that hot food, hot drink. So even that area contains stratified squamish epithelium. So nasopharynx, respiratory epithelium, because you're not introducing food into your nose, right? So what happens? Areas where we're introducing food and liquids, that area contains stratified squamish cells. So as we move down, right, laryngopharynx will eventually turn into your esophagus. That is going to have food going through it. That's going to have stratified squamish cells as well, right? On the other side of it, right, on the anterior side of the laryngopharynx, is going to turn into trachea. Well, that area we're not going to have any food go through, hopefully, right? If we do, we're going to choke. So that area, we're going to start seeing a different type of epithelium again, respiratory epithelium again, right? The larynx, voice box, cartilaginous chamber, main function is to keep food and drink out and to produce sound, all right? So the larynx, right, maintains your, open airways, also acts to keep the food and drink out of the airway, right? And for us, allows us to make sounds and turn it into speech. So down here's our larynx, right? Anterior part, anterior start of our kind of respiratory system only, right? Now, we'll talk about these cartilages, right? The thyroid cartilage, here's our hyoid bone, thyroid cartilage, cricoid, and the rest of it is the trachea. Understand that, right? The very start of our respiratory system, right, contains a lot of cartilage for a reason. Cartilage usually is very strong and it allows us to maintain an open airway. That doesn't mean food can't get stuck there, right? Food that's thick enough can usually when that happens, we need to somehow expel it out, right? And we do that by doing that, a little maneuver to basically cause your abdomen to go in and your diaphragm to go upwards, right? All right, the epiglottis. Epiglottis, flap of tissue that guards the superior opening of the larynx. At rest, it stands up almost vertically. During swallowing, muscles there pull the larynx upwards. The tongue pushes the food into the epiglottis. So what happens is this, right? You have the epiglottis that's like the flap right here, right? And then you have the trachea, right? That's right below it. So what happens is to completely cut, all right, and make sure that food doesn't go into the trachea, the windpipe, what happens is when we swallow, our throat actually elevates. As it elevates, the epiglottis moves down. At the same time we elevate. What happens? We form a seal, right? That's exactly what we want. Now, if we don't elevate, the epiglottis goes down a little bit, but there's no elevation. What happens is there's a little gap for liquid to seep its way through, right? So we need that elevation, all right, and the flap to close at the same time. That forms that seal. The vestibular folds play a greater role in keeping food and drink out of the airway, right? The epiglottis and the vestibular folds basically allows us to deflect the food matter so then it doesn't go into the airways. So here's the epiglottis right here, right? And we'll talk about some of these in the afternoon. So we're gonna skip the larynx right here just because we'll kind of discuss it, right? Well, we'll talk about it a little bit. So you guys know the thyroid's over here, the thyroid cartilage, right? You guys know, probably have heard of Ronaldo, right? He's not really good looking or anything, right? He's got that thyroid cartilage that kind of meets up there, makes him look ugly almost, right? And what happens is you guys have probably seen people with a real pronounced Adam's apple. And usually they're men. It doesn't have to be men, right? It can be, all right? Usually men. So usually when you pronounce Adam's apple, the reason for it is the angle at which the thyroid cartilages meet is a little bit more sharp, right? That's all it is. It's a little bit more sharp. Now, what also happens because it's a little bit more sharp, the vocal cords are a little bit more stretched, right? Allowing us to have a much, for guys, a little bit more lower tone to our sound, right? But that is one of, they kind of work together. So the thyroid cartilage is below the epiglottis, right? We're going to see the thyroid gland lay a little bit inferior and lateral to it. Then behind it, and a little bit slightly inferior to it, you have the cricoid cartilage. The cricoid cartilage has these cartilages that are resting on top of it, arytenoid and corniculate, right? So you have the cricoid cartilage right here that is inferior to the thyroid. The cricoid cartilage has two cartilages resting on top. One is called the arytenoid. The second one on top is called the corniculate. Now I'm mentioning this because, right, I've got to do numerous intubations. Intubation is always fun. It's always scary as hell too, right? So when we put somebody kind of like into sleep under general anesthesia, right? During surgery. What happens is we put you to sleep. What happens when you're asleep? You move around a bit. That's not good for surgery, right? So not only do we have to put you to sleep, we want to give you a paralytic. So when you are under general anesthesia, right, you are given a paralytic and it allows you to paralyze all of your skeletal muscles, including your diaphragm. So then you can't breathe by yourself during that surgery. That's why I have to put the tube into your mouth, into your throat, into the trachea, right? Because you can't breathe. So one of the things that's really hard to do, right, when you are eventually put to sleep and I paralyzed you, right, you can't move your vocal cords. If you can't move the vocal cords, the opening to your trachea is completely closed off. And most people don't want you to just ram that tube right down their vocal cords and damage your vocal cords, right? So what do you have to do? How can you open it up? How you open it up is by applying pressure right on your cricoid. See what happens to my voice once I put pressure on my cricoid? What happens is when I put pressure on my cricoid, all right, I cause my vocal cords to be in a forced abduction. I cause it to open slightly, right? And when I'm doing it even to myself, it causes a change in my voice, right? When a person is completely asleep and paralyzed, it opens up the vocal cords completely, allowing me to put the tube down the throat. We call it cricoid pressure. EMTs do this a lot, right? Obviously, anesthesiologists do this a lot as well, right? This cricoid pressure allows us to move the arytenoid cartilages, corniculate cartilages, and it causes a forced abduction and opening of the vocal cords. So now we can bring the tube into the windpipe or trachea. A little bit more on this afternoon. All right. Vestibular folds. What do you need to do? No. All right. Vestibular folds right here are superior to the true vocal cords. They don't play a job at all in kind of speech and sound formation. Their main purpose is to make sure, along with the epiglottis, that there's no food that gets into the trachea. Now, the reason is simple. It's much easier to move mucus out of the trachea and your respiratory system. But if you have a solid food matter that's found there, right, and it's going into the trachea, it becomes really hard to get rid of, right? Usually, in order to get rid of it, and usually we see this with kids that swallow maybe a peanut a little too early, a little too fast, right? What happens is it blocks off one of the main uh, bronchi, so that air can't get easily through one of the lungs on one of the sides. So what happens is, and it's going to sound gross, right? It gets trapped there, but because a little bit of air can get through and then the other side's not affected, usually we don't see like that person, that child, really in severe distress because we're still getting air a little bit in, right? Usually what really makes it distressing is that their voice and when they talk, right, changes. And right, when they breathe and everything, it starts to really smell, right? And that's one of the first signs that there's, you likely infection there. And it's caused by that food matter that's now stuck in the bronchus. And now we have to get rid of it somehow, right? Because it's so thick and heavy, you can't cough it up. So the only way we can get rid of it is to actually do an endoscope and look into a bronchoscopy and look into the actual lung. And then take what looks like little tweezers to get it out, right? But yeah, it does happen every now and then, right? In other words, superior vestibular folds and a combination of epiglottis isn't always foolproof, right? The inferior folds are called the true vocal cords. They produce sound when air passes through them, contains vocal ligaments, and covered with stratified squamous cells because stratified squamous cells are going to be important in protection, right? Best suited to endure vibration and contact between the vocal cords. The glottis right here, right, is the opening in the vocal cords. So epiglottis, trachea, This, all right, over here, tracheal or thyroid cartilage, and then trachea down here, right? Here are the vestibular folds, and then the true vocal cords are slightly inferior. And usually when we're looking at these, right, the vocal cords themselves look white, right? And we call them the pearly whites, like the pearly gates, because once we see the pearly whites when we're doing intubation, we know we're in good shape, right? All I have to do is correct my pressure, and then it opens up. Muscles control vocal cords. They pull on the corniculate and arytenoid cartilages, causing the cartilages to pivot. As they pivot, the cartilages are attached to vocal cords, causing them to abduct, right, or rotate. Air force between the adducted vocal cords vibrates then, producing high-pitched sound. Right. So I didn't highlight any of this as more physiology, right? That I don't, right? We got it through the vocal cords. There's no obstruction. Air's gonna go into the windpipe or trachea, right? The trachea right here, rigid tube about 12 centimeters, 4.5 inches long, and 1 inch in diameter. That's like this, right? Now, usually for kids, their trachea is about the size of their finger, right? Their little finger. That's how small it is. That's why it's much easier for kids and babies to get things stuck in here, right? Now, the trachea is 16 to 20 C-shaped rings of hyaline cartilage. And from now on, when you hear hyaline cartilage, that is there for support and maintenance of an open passageway. Bless you. Right? So that's there for an open passageway. Right? Because remember, smooth muscles collapse. Cartilage doesn't. Right? Now, could have bone there, but bone is a little bit too static, right? It's not going to move as much as we want it to. Now, it's C-shaped for a reason, right? In the back of the C-shaped rings, we're going to see a muscle called the trachealis muscle, right? There, the gap in cartilage allows room for the esophagus to expand as food is swallowed into the esophagus, right? Now, easiest way to kind of understand this is understanding that what would happen instead of being C-shaped, if it's O-shaped, if the whole thing is made out of, if the whole trachea is made out of cartilage and it's O-shaped, what would happen is this, right? Remember, behind the trachea, we're going to have the esophagus. In the esophagus, you're bringing food down, right? One bit at a time. As you swallow food, right, it takes 4 seconds to take food from your mouth once you start swallowing. It takes 4 seconds to bring it into your stomach. 4 seconds, right? Most people don't think it takes that long because you know what? We start the swallowing process, we don't have to think about it anymore because we have smooth muscles and reflexes that take over, right? But it does take 4 seconds. So what happens? We're bringing that food bolus, and then we have to squeeze it into the esophagus. From one part of the esophagus, you squeeze it down. Then you have to squeeze it to the next part, right? And then the next part, and then the next part. As you squeeze that food down, this bolus of food, right, is behind your trachea. If your trachea were O-shaped, every time you swallow, right, and move that food down by squeezing, your trachea will move in and out, right? Every time that piece of food goes and we move it a certain distance, your trachea will have to distend outwards. And that's not convenient at all, right? Especially when it takes 4 seconds for each bite to be swallowed into your stomach. We don't want that deviation of the trachea every time you swallow. So we have, instead of an O shape, we have a C shaped ring. In the back, that trachealis allows you, when food is swallowed and the esophagus behind it, we can push in a little bit. But the whole trachea doesn't move forward. Right? We can push in on the trachealis, right? Without moving the whole trachea forward. A little bit more control when we swallow. So here's your trachea right here with the C-shaped rings. As the trachea moves air down, it's then going to split in two, right? The first two regions right here, right, are called the primary bronchi, right? The left primary bronchi, or bronchus, is going to separate first, and then the right. Why? Because of the presence of the heart, right? Now, because of the presence of the heart, the left lung area, right, only has two lobes, right? The right side, we have more room. You don't have that big, thick heart in the way, right? So you actually have an unequal asymmetry here, right? Where you have more lobes in the right side and more lung matter on the right side than on the left, right? Again, the primary bronchi and bronchus right here, all right, here's your right and the left, right? The left one diverts first, then the right one, right? Just a little bit different right here. And then the primary bronchus is going to split into three secondary bronchi that corresponds with three lobes, right? Now, the primary is the first branch, right? Then we're going to split from that first branch, right? So primary goes into a couple secondaries. Each of the secondary bronchi that we're going to talk about, right, is going to go to a lobe. So here on the left side, we have two secondaries, one, two. That's going to correspond to two lobes on the left side, superior, inferior lobes. On the right side, we have three, right? One, two, and then three on the way down, right? That's three secondaries, three lobes on the right. More room for lung matter. Right. The inner lining of the trachea, now there's a change, right? Before we go from the nasopharynx, respiratory epithelium, oropharynx, stratified squamish, right? Laryngopharynx, stratified squamish, esophagus, stratified squamish, right? As we divert forward and we turn it into the trachea, now we switch back to respiratory because only, food should not come into this region at this point, right? Only air should. So we don't need that protection. We have then the respiratory epithelium, which is ciliated pseudostratified columnar with lots of goblet cells, right? The mucociliary escalator, the mucus traps any inhaled particles. Then the cilia, right? Now right, the trachea is below the vocal cords. So when it's below the vocal cords, the cilia beats and moves any mucus upwards. Remember, the whole point is to swallow it down. I know, scroll. So anything if it's kind of, below the vocal cords, the cilia moves all that mucus with trapped particles, right, upwards. If it's above the vocal cords, it moves it downwards, right? Perfect. Now, the next picture is just going to show you just, right, what the cells look like. Again, how do we know what this is? Right? Pseudostratified columnar because you see nuclei at multiple levels. You see cilia, right? So right away when you see cilia here, we know it's either simple or pseudostratified columnar. You don't see cilia with any other cell type. And then you see nuclei at multiple levels. One here, here, all the way down, right? Immediately is pseudostratified. To the left and right main bronchi. The internal ridge where we separate is called the carina. The carina directs airflow to the left or right sides. And here's a good picture next of our trachealis muscle. Remember, the trachea is C-shaped, right? The trachealis muscle right here is kind of right encloses the rest of the C. And what happens then is when we swallow, right, instead of moving the actual trachea forward, we just make an indentation into the trachealis. We push it into the trachealis, right? Perfect. It's a good picture. Might have to steal it, right? right? Left side, we have the superior lobe, inferior lobe. You guys know how high up? So here's the apex of the lung. Here's the base of the lung. The base of the lung is the area of the lung that makes contact with the diaphragm, right? It's very bottom. The apex, do you guys know how high up the apex of the lung is? All right. It's about 2 to 3 centimeters above your clavicle. All right. So it's above your clavicle. People have, right, collapse of lung when they have, right, a fractured clavicle that fractures internally. Question? It's pretty high up, right? We don't think about it. I remember I was doing the first central line I've ever had to do. The central line is the scariest thing you'll ever do, right? Or you'll ever hear of. Why is a central line so darn scary? Number one, it's an artery we're trying to tap, right? So we're trying to go into the carotid artery, right? Number two, just like with all arteries, you don't see it, right? You don't see that artery. So you have to feel it by palpating for a pulse and then go through the skin and the fascia and the muscles and then go into the carotid artery, all without any kind of visual help, right? Now, the one thing I was in the ICU with my attending anesthesiologist, and as a resident, I'm trying to do it, and at the same time, he's trying to freak me out a little bit, right? Because that's weird how that works as doctors, right? He's like, yeah, just, reminder, right, that if you go too deep, you can collapse this person's lung. I'm like, what? Right? This is what you're telling me now? And he goes, yep. Last month I did one of these and I accidentally collapsed the apex of his lung. Right now, it's not that bad because there's not like a lot of lung matter there. There is some, right? But not a lot. What we do, and when we collapse the lung is, all right, we have the parietal pleura that we're going to talk about all right, coming up, is a kind of a connective tissue seal on the inside of our rib cage, right? Well, that seal has to be complete. All right. When it's complete, it forms a vacuum in our thorax. So then when your rib cage moves, it opens up. All right. Your rib cage is moving, your whole rib cage moves, the parietal pleura moves with it, that pulls the actual lungs open. Right? Perfect. But what happens when you don't have a complete parietal pleura and you just puncture a little hole in it? What happens is a little air moves in there, right? So as the rib cage move, there's no longer a vacuum to force the lung open. A little bit of air is enough to prevent you from pulling that lung open and air going into that area of the lung, right? So it is high up enough that if you do have a fracture of the clavicle internally and you have a hard time breathing, it's probably collapsed lung, right? That can happen. Now, in terms of the lung itself, right, we're going to talk about the lobes. We're going to talk about these, all right, separations that we call fissures. All right, the area of the lung matter where, right, the secondary bronchi, the pulmonary arteries, the pulmonary veins all enter and exit. That area is called the hilum of the lung. So the hilum of the lung, all right, is the area where everything enters the lung. That's all. All right, is where all the blood vessels enter the lung, where the blood vessels exit the lung, right? Where the conducting, right, usually the secondary bronchi, right, enters the lung, right? So the hilum is a specific area of lung where everything enters and exits. Take a look at how big our aorta is right here. And here's your pulmonary trunk, right, leading up to your pulmonary artery. I don't know if you guys see this right here. Do you guys see this little thing right here? Right? This is called a ligamentum arteriosus. Right? You guys know that when we are first conceived and we start growing in our moms, right? That we actually have two physiological holes in our heart. Right? The reason why is simple. When we're in utero, is there any oxygen we're breathing? No, right? So why bring blood to the area where there's no oxygen? Why bring it to the lungs at all, right? There's no reason. So very, very, very little air, very, very little blood flow occurs so then we bring it to the lungs, right? Because there's no need. There's no oxygen there. So what happens is when we are in utero, right, blood goes from the left atrium directly to from the right atrium to the left atrium. There's a hole between the atrias, right? Now, whatever blood does go into the bottom right ventricle right here goes up into the pulmonary trunk and through this opening, right? We call the ductus arteriosus. So when you hear babies that are first born with a heart murmur, right? Or with what they call holes in their heart, and usually the doctors aren't worried about it, is usually because, right? Usually, right? What happens is either one, this one, or the hole between the right and the left atrium hasn't fully closed yet. It will close within the first few months of life, right? Now, should there be a hole between the two ventricles, main pumps? No. If there is, we have an issue, right? That usually causes blue baby syndrome. And if we can, we'd like to do surgery in utero to fix it, right? The lung itself, conical organ with broad concave base. Apex projects slightly above the clavicle. The hilum slits through which the lung receives the main bronchus, blood vessels, lymphatics, and nerves. Right. So this is a lot more of like the anatomy, which we'll kind of discuss a lot more detail this afternoon. Right. What else? All right. Right lung. Now this is what what do we need to know? The right lung, shorter than left, has three lobes: superior, middle, inferior, separated by the horizontal and oblique fissures. Right? The right lung. The left lung, taller and narrower, right? Smaller in terms of total volume because of the presence of a very large heart, right? Has indentation called a cardiac impression. We call it the cardiac notch usually. Has two lobes, superior and inferior, separated by one single fissure. Right? Remember, right? We use the term fissure when we talked about the brain and the spinal cord, right? A fissure there completely separated something. Same thing here. A fissure completely separates the lung matter. It separates it into superior and inferior lobes. Okay. Now more pictures, and we'll talk more about these coming up. All right. Here's that cardiac notch. All right. Bronchial tree, a branching system of air tubes in each lung. From main bronchus, we have up to 65 terminal bronchioles coming out of it. Just these numbers are crazy, right? So if one main bronchus, right, is going to divide into three secondary bronchi on the right side, two on the left. The secondary bronchi are going to split into a lot of tertiary bronchi, which are then going to turn into bronchioles. By the time we're done, that one bronchi will turn into 65,000 terminal bronchioles, right? And it's all resting in our thorax, and that's it, right? I'm just going to highlight one area right here that kind of shows us the difference between the right and the left. The right main bronchus, slightly wider and more vertical. And because of it, inhaled particles, inhaled foreign objects, right, usually get stuck there. Because it's bigger, it goes right through, right? The left is about 5 centimeters long, slightly narrower, and more horizontal. Right, let's take a little break.